PSMA-Radioguided surgery detecting nodal metastasis during robotic-assisted radical prostatectomy, an interim analysis of a prospective Phase 2 study. There are no conflicts of interest to disclose. Prostate-specific membrane antigen is a transmembrane protein highly overexpressed on prostate cancer tumor cells. PSMA can be safely and effectively targeted using gamma-emitting radionuclides. 99M technetium PSMA imaging and surgery represents a valuable option at a relatively low cost. 99M technetium PSMA imaging and surgery has shown a strong in vivo stability and a relatively slow whole body clearance. This allows a steady increasing lesion to background ratio up to 21 hours after injection. This study was a Phase 2 single institution, non-comparative, non-randomized prospective study with 100 patients which need to be enrolled. The inclusion criteria were that men have to have no nodal or metastatic sites at conventional imaging, and the risk of lymph node invasion had to be over 5% according to the Briganti nomogram. The aims of the study was to optimize the synthesis of 99M technetium PSMA imaging and surgery, to assess the safety and tolerability of the administration of the radionuclide, and to describe the use of 99M technetium PSMA radioguided surgery in nodal staging in prostate cancer patients. Herein, we are reporting the interim analysis on the first 48 patients enrolled in the clinical trial. The patient workflow consisted in an outpatient evaluation followed by a 68 gallium PSMA PET MRI 7 days before surgery, and the day before surgery, patients underwent 99M technetium PSMA imaging and surgery infusion. Regarding radionuclide safety, 68 gallium PSMA had an activity of 157 megabecquerels, and for 99M technetium PSMA, the dose was 732 megabecquerels. There were no adverse events for either the 68 gallium or the 99M technetium PSMA administration. For the surgical procedure, a drop-in gamma probe was used for in vivo intraoperative measurements to identify metastatic lesions at the level of the internal iliac, external iliac, obturator, and common iliac stations. A positive finding was defined as the count rate of at least 2 times compared to background. All positive lesions were excised, and ex vivo gamma measurements were performed to confirm the removal of the radioactive lesions. All procedures were performed with the Da Vinci Xi robot in a 4-arm configuration with a transperitoneal approach. After isolation of the seminal vesicles, the peritoneum was re-incised and the bladder released laterally until the endopelvic fascia and the ureters were identified. This allowed exposure of the pelvic lymph nodes. At this point, a drop-in gamma probe was inserted through a 15mm assistant port. It can be autonomously grasped and directed by the console surgeon using the robotic progress forceps. Externally, a control unit provides both acoustic and numerical feedback as a response to 99M technetium activity and can be used for intraoperative surgical guidance. Fibrofatty tissue within the obturator fossa was removed, and the dissection was performed from lateral to medial up until the umbilical artery, and the bladder wall represented the medial limit. Similarly, lymph nodes along as well as medially and laterally to the internal iliac vessels were removed. Presacral nodes were also removed. After removal of the fibrofatty tissue, ex vivo gamma measurement was performed to immediately confirm the removal of the lymph node lesions and to prompt further search in case of missing signals. After completing the prostatectomy, the gamma probe was used to assess the presence of 99M technetium PSMA imaging and surgery uptake in the prostatic fossa. And at the end of the surgery, the prostate and seminal vesicles were also measured ex vivo. Regarding perioperative outcomes, surgical time was 215 minutes. The average number of nodes removed were 22. Length of stay was 4 days. There were no intraoperative complications. 2 patients reported low-grade complications, and there were no high-grade complications. Comparing PSMA PET and radioguided surgery, lymph node invasion was correctly identified at 85% in the PSMA PET and in 64% in radioguided surgery. Radioguided surgery exhibited a 36% false positive findings, and missed lymph node invasion was 18% in the radioguided surgery, compared to 33% in the PET PSMA with gallium. Overall, on a per-region analysis, sensitivity was 58%, specificity 87%, positive predictive value 40%, negative predictive value 93%, with an overall area under the curve of 83%. On a per-patient analysis, sensitivity was 87%, specificity 70%, positive predictive value 56%, negative predictive value 92%, with an overall area under the curve of 75%. To conclude, robot-assisted 99M technetium PSMA-Radioguided surgery is a safe and feasible procedure in clinically node-negative and metastatic-negative prostate cancer patients undergoing robotic-assisted radical prostatectomy with extended pelvic lymph node dissection. It can enhance our capability to detect positive nodes identified by preoperative imaging intraoperatively. Nevertheless, it is characterized by suboptimal sensitivity, especially in micrometastatic disease or men with a high nodal burden.